Dear Pure Urology Facebook viewers, good evening one and all. After our national conference last 5 days in Delhi, we are coming back with this program again. To get disturbed during the national conference we have not conducted in the last week. As you all know, female urology is becoming a specialty branch. Even Urology Society of India has separated female functional urology section because it's a big subject, right from the recurrent UTI, urethral stenosis, incontinence. Incontinence itself is a big subject. Stress incontinence, urge incontinence, mixed incontinence, urodynamic study, cystocele, intrinsic sphincter deficiency, the supportive deficiency, central, lateral. So many terms are there. So subject is so much. As a matter of fact, as an endourology surgeon and laparoscopic surgeon, I have limited knowledge, but I hope I will be able to conduct this interview with Dr.Amita Jain, who is our speaker, and she has good track record. That's why she's also working in Medanta Medicity. So before I introduce her CV officially on the PPT, I will ask some of the questions to Amita Jain, madam. Madam, thank you for accepting the invitation, and it is highly appreciated that you have concentrated continuously after your gynecology on the urology. I know many of the gynecologists will leave the gynecology and go to the urology, and female urogynecology is a subject. There is nothing wrong once you are dedicated to that field, and that too, you are working in a prestigious institute like Medanta Medicity. Thank you once again. Where is your primary education, madam? MBBS, where is your education?
So I got my MBBS done in KGMC, King George Medical College.
Lucknow, madam?
Yes. After that, I did my MS Option Gynae from Sarojini Naidu Medical College, Agra.
Agra, okay.
So after that, I did my fellowship in urogynecology from Queensland University from Townsville, Australia.
Okay, there. How did you go there? What is the motivation? Who is your mentor? How it has happened actually after MS?
So I prepared for MRCOG Part 1, and at that time I got introduced to this subject of urogynecology. Okay. So I was looking for a kind of mentor, and I have been told about Dr. Jain, who was interviewing fellows. So I just contacted him, and I was lucky enough that he actually accepted my request, and I got the fellowship.
To do the fellowship in Australia, you need to do anything like IELTS and all that?
So at that time, I told you that I was lucky. I got an invitation letter from James Cook University at the time, and I just went there and visiting fellowship. But because
so do you think that their system of education is very good? I heard.
Yeah, but nowadays I heard that they need a kind of examination. You have to pass examination before entering into.
How many years you have spent in this urogynecology fellowship?
No, it was not years. It was a very short-term fellowship. It was for 3 months only. Okay. And after that,
you continued the work in the same field?
Yes, I joined urologist after that.
Is it?
So I am constantly working with Dr. Rajesh Alawat team for last 12 years. So I learned a lot from urologist itself. So it's not like the training continues.
Great. So I really appreciate. With this, I will share my screen, introducing her more officially about your career. Thank you, dear friends, for watching the program Laparoscopic Bruch Colposuspension Revisited. Many knows open Burch colposuspension has been there for years for stress incontinence. There are certain lacunae, there are certain advantages. In failed cases, still it can be used. Let us listen from Dr. Amita Jain. She is Senior Consultant Urogynecologist at Institute of Urology and Robotic Surgery, Medanta Medicity Hospital, Gurgaon, Haryana. Founder member of Female Pelvic Pain Association, Southern Asia representative of International Advisory Board at International Urogynecological Association 2022 to 25. That means still she is. Member of Scientific Committee of International Urogynecological Association 2021 to 23. Appreciation Award from Association of Obstetrics and Gynecologists of Delhi 2017, International Continence Society Travel Award 2015. She has published more than 40 papers. With this introduction, we hand over the program to Dr. Amita Madam. Madam, over to you. You can share your screen and proceed, please.
Thank you so much.
Yes, madam, it is visible. You are audible.
So thank you so much, Dr. Chandra, for giving me this opportunity to speak upon laparoscopic Bruch Colposuspension. And obviously it is revisited because now we are having interest again in this forgotten, very good surgical procedure. So it was John Burch who first introduced it in early 90s, and it was actually accidentally once he was doing a procedure of Marshall Cranch operation for treatment of stress and urinary incontinence only, and because he was not able to attach it with a bone, so he found out some other stout structure, and in this way this procedure was invented. So it was a gold the procedure of choice in early 90s. You can see this graph which is showing the popularity of this procedure in early 90s, but after the introduction of tension-free vaginal slings, like it was first pubovaginal slings in 1987, then it was from Petros and Lumsden in TVT in early 90s, and then in 2001 the Delnor introduced TOT. After that, you can see there was decrease in the popularity of colposuspension, and suddenly the sling procedures rate increased because of it was minimally invasive. People used to do open colposuspension, which was invasive operation. You have to go through abdominal route. So that's why the procedure of choice become the sling procedure. But what happened after 2011? You all know that there was FDA safety communication against the surgical mesh, though it was particularly for the mesh used for vaginal repair, that is pelvic organ prolapse. But it was also reclassified from class 2 to class 3. But the negative publicity actually impacted the synthetic mesh used for even stress urinary incontinence. And you can see in this graph that the per year procedure so much decrease from 2011. It was a constant decrease. But again, what was the solution? You can read this column of World Without Mesh in latest edition of Campbell, where the author has quoted that as synthetic mesh use become more restricted, there may be a change in practice towards autologous sling material or colposuspension in the future. And many of the guidelines has already, included these two procedures as procedure of choice for treatment of stress urinary incontinence. So if we talk about what should be choice between autologous facial slings and colposuspension, so there are many data, and it has been seen that though the facial slings are more effective probably in rather than colposuspension, but there is a kind of few complications which are more than open colposuspension. This study was done in 2007, and it has been found that particularly post-operative voiding dysfunction, it is quite high with pubovaginal slings, as high as 14% versus 2% with Burch colposuspension. The de novo urgent continence is also pretty high, and there are higher chances of urinary tract infections and reoperations. So that's why finally, this was the kind of decision analysis which was published in 2000, and it was advocated that Burch procedure should be considered if the risk of urinary retention or detrusor instability is higher than 10% in women undergoing slings. Then actually what would be the solution if we just want to avoid an invasive procedure, we want to go for a minimally invasive thing? Then obviously answer is laparoscopy, and it was actually way back introduced in 1991. But the problem was a steep learning curve with the laparoscopic procedure. So that's why several modifications has been introduced, like use of clips instead of traditional sutures, staple mesh as a fixation method, or placement of only one suture per side. Otherwise, traditionally we put two sutures on both the sides. So all these actually showed failed results because of the compromise in the continence rate, the success rate. So that's why abandon. Then why we should choose minimally invasive way of colposuspension. So in long run, it has been seen that the database, the Cochrane database, is showing that the subjective and objective cure rates are almost similar of both the methods, open and laparoscopy. And the advantage of laparoscopy is that there would be low perioperative complication, less intraoperative blood loss, post-operative pain, and that's why the hospital stay will be shortened and patient can join its normal their normal activity as soon as possible. And also need for catheterization for avoiding dysfunction and everything were lesser in laparoscopic approach. The only disadvantage apart from the steep learning curve was longer operating time. So it has been seen that as much as if you will do and you get expertise in the procedure, probably you can comfortably take this procedure in a minimally invasive way. So the latest is the robotic Burch colposuspension, which actually makes the things easier. The only thing is the cost factor, which probably will be lesser and lesser once we have a kind of, different kinds of robotic, machines in the market. So you can see that I was just reading today only, and I can see that it was quoted that it was first reported by Francis and colleagues in 2015. Then I just actually called USI and I told that I have presented it myself in 2013 in annual conference of urology. The presentation name was Robotic Burch Colposuspension, an expensive gimmick or need of the future. And today, actually, I'm going to show you the video of that same procedure which we operated in 2013, and the steps will be same. You can replicate it in the open way or as well as in the laparoscopic way. And there is also a YouTube link for this thing. Yeah, here this this busy slide can show you that whatever has been done to modify the procedure, the laparoscopic colposuspension has actually caused the compromise in the continence rate. And other comparison, you can see that definitely there is advantage of doing it in a minimally invasive way. But still, you can see in this slide that there is decrease in the rate of doing mid-urethral sling after the FDA warning, but there is no rise in other kinds of procedure. Like you can see here clearly, the colposuspension, why it is not being used more commonly, how to address the patients with stress incontinence once you can't use the synthetic slings. Even the autologous slings is not being used. And you can see the result is lack of training and expertise. That is the cause of we cannot see any rise in these procedures. Even the patient's pool is increasing day by day. So first we have to understand what is the mechanism.
Historically, the surgical treatment of stress urinary incontinence by reinforcing the supports of urethra to restore its normal intra-abdominal position was first achieved by retropubic suspension of periurethral tissue like colposuspension. In 1961, initially Burch described attaching the paravaginal fascia to the arcus tendineus. However, he later changed the point of attachment to Cooper's ligaments because these were felt to provide more secure fixation points, and later on in 1976, Tanego modified the procedure by placing the sutures in a far lateral position, used two sutures bilaterally, and emphasized avoidance of undue tension on the anterior vaginal wall. He commented that two fingers could be placed between the symphysis and urethra and stressed that the vagina did not have to be contiguous with Cooper's ligament. This concept of not over elevating the vaginal wall is consistent with the hammock hypothesis of John O.L. D. Lancey that explains the role of antevaginal wall support for urethral continence, especially at the time of high intra-abdominal pressure. Therefore, just stabilization is required to avoid overcompression of urethra so that the patient could experience cure with less risk of urinary retention and bladder overactivity secondary to obstruction. Indications include women who decline or have persistent symptoms following a trial of conservative management, women with mixed urinary incontinence who are able to control their symptoms of urge incontinence and provide enough motivation that surgical management of stress urinary incontinence is essential for them to improve their quality of life. The patient requiring concomitant abdominal surgery that cannot be performed vaginally is also a candidate for Bruch Colposuspension. Contraindications: patient with a fixed non-functioning proximal urethra are not candidates for a Burch procedure as no hypermobility exists to correct. Women who have not yet completed their childbearing should delay the procedure because pregnancy disrupts pelvic support. Both vaginal delivery and cesarean section have proven to show recurrent incontinence after anti-incontinence procedures. Lastly, all patients should be evaluated to determine fitness for surgery as this is an elective procedure. Caution: the Burch procedure does not allow for correction of central defect cystocele, rectocele or introital deficiency, and thus consideration of an alternative treatment is indicated. Our recommendation is that the procedure be performed only if the patient has adequate vaginal mobility and capacity to allow elevation and approximation of lateral vaginal fornices to Cooper's ligament on either side. Therefore, although it may be used in the setting of a prior failed repair or previous radical pelvic surgery, patients should be warned that success rate might not be as good as in naive patients.
Yes, madam.
Historically, the surgical treatment of stress.
Next.
Sorry. The question comes that whether urodynamic testing should be performed before this surgery. Then the answer is that not in all patients, but yes, if there are symptoms of overactive bladder, detrusor instability is suspected, then probably it's better to rule out this beforehand because the success rate would be not as good as if it is a pure SUI patient. Also, if patient is giving history of any kind of voiding problems and you are suspecting voiding dysfunction, especially in case of anterior compartment prolapse, that is cystocele, and if patient already got a surgery for the same problem, that is stress urinary incontinence, then in these cases it's better to perform a voiding cystometry. Otherwise, in usual practice, we just do a non-invasive urodynamic study, that is uroflowmetry, just to understand the patient's flow pattern and to rule out any other condition. And I was the part of this Urological Society of India guidelines on evaluation and management of urinary incontinence, and even in this guideline we have concluded with the same that we should perform an invasive urodynamics before initiating surgical treatment, not before initiating non-invasive treatment. So that is clearly depicted in this guideline as well. Now, what could be the counseling to the patients before doing the surgery? So we have to tell about some kind of the complication which are common, like bleeding. It usually occurs once you are not removing the fat in the operating area adequately, and then you won't be able to see the underlying veins. Usually there would be veins of Santorini or something which can be injured, and that can cause bleeding in around 0.7 to 3% of the patients. Again, the bladder injury, it usually occurs in the setting once the previous pelvic surgery, cesarean sections are there, or something is there which can cause adherent bladder. And so otherwise, sometimes urethral kinking or urethral injuries has also been seen in these patients. So it's always advisable to do a cystoscopy after the procedure so that you can confirm that there is no injury of urinary tract.
Potential complications should be discussed with patient before surgery. Overall risk of de novo bladder overactivity is around 12 to 19%, and the cause could be multifactorial. It may occur due to increased outflow obstruction or due to damage to autonomic innervation during dissection. Mostly it can be easily managed by anticholinergics and behavioral modification. Rarely in refractory cases, botulinum toxin or erythrolysis may be needed. Post-operative voiding dysfunction could be early or late, with overall incidence of around 5 to 10%. It occurs mostly due to overcorrection of urethral axis or over-tightening of sutures, as discussed before, and may be prevented by correct placements of sutures. Moreover, too medially placed sutures may cause transfixation of urethra, though in most cases it resolves spontaneously by 4 weeks, and patients may be explained the possibility of the need for intermittent self-catheterization, but in severe cases, retropubic erythrolysis may be needed. Also, this complication manifests more in patients with previous history of voiding dysfunction. Therefore, preoperative assessment to rule out pre-existing voiding problems become essential.
Other delayed post-operative complication could be occurrence of urinary tract infection, which is seen as less as 4% to as high as 40%. It all depends on your operative technique, and again wound infection, which is pretty common with open ones. So all these complications will be lesser if you are going for laparoscopic Bruch Colposuspension. Now showing the video of operative technique.
Operative technique. These surgical steps I will be showing next in detail. Medial umbilical ligaments on both sides are first identified, which helps to decide the lateral limits of dissection. The dissection is started from right side by pulling the right medial umbilical ligament. The retropubic space is progressively developed by gently separating the adipose tissue behind the symphysis between the bladder and pubic bones, using both sharp and blunt dissection till endopelvic or pubocervical fascia is reached. This figure illustrates the view of retropubic space or space of ridges from above and clearly demonstrates its boundaries, which are rectus abdominis and symphysis pubis anteriorly, the pubic rami and obturator internus laterally, bladder and proximal portion of urethra posteriorly, and endopelvic fascia infralaterally. The veins of Santorini runs within the vaginal wall and are commonly encountered during dissection. Other important vascular structures that may be encountered in this space include the obturator neurovascular bundle, the aberrant obturator artery and vein, and the external iliac artery and vein. The bladder neck is identified with position of the catheter bulb on gentle pull down of Foley's catheter by vaginal assistant. To assist in identifying the anterior vaginal wall, vaginal assistant can place a gloved examining finger in the vagina to tent the vagina anteriorly. The arcus tendinous fascia pelvis or white line can be seen clearly. It stretches from the posterior aspect of the symphysis pubis and continues in a downward sloping direction along the facial margin of obturator internus muscle to terminate at the shell spine. You can also appreciate pubococcygous muscle, a part of levator ani, taking origin from the arcus and funneling downward into depth towards the midline. Cooper's or pectineal ligament is also exposed by clearing the overlying fatty tissue of the lateral pelvic wall. It consists of a white band involving the periosteum of the superior ramus of the pubis along the pectineal line and offers better tissue than periosteum for suture placement as there is no risk of osteitis pubis. Now, space is created from left side also after cutting the left medial umbilical ligament. The advantage of superior ergonomics of robotic technology can be utilized to avoid large plexus of vessels commonly encountered in this highly vascular space, and in this way we can minimize the intraoperative blood loss. This side also the periurethral space is cleared of overlying fat to expose white shining pubocervical fascia, and same steps are repeated to demarcate the lower vesical margin, urethra and vagina. The dissection in middle can be avoided in open approach as identification of urethra is easy by palpation of the catheter itself. But in robotic approach, we rely on visual identification. Therefore, complete exposure of urethra and bladder neck is especially useful to clearly define the site of placement of sutures. Large vessels like dorsal vein of clitoris can be encountered in this area, and if required, hemostasis can be achieved with help of sutures, clips or cautery. You can now clearly appreciate the bladder neck and whole urethra. Partially filling the bladder further help in defining the rounded lower vesical margin. The first proximal suture is placed at the level of bladder neck and about 2 cm lateral to it on left side by using delayed absorbable sutures. And taking 2 vertical bites to lessen the risk of the suture pulling through and then taken through corresponding side Cooper's ligament. On contralateral side also, proximal sutures are placed at the same level with a good bite of anterior vaginal wall and overlying fascia for optimal support, again attached to the Cooper's ligament of that side. Then the distal sutures are placed at the level of mid-urethra, again taking a good double bites of tissue. The full thickness suture placement can be done while using delayed absorbable sutures, as it is less likely to tear through the venous plexus of anterior vaginal wall and also gives a better support because mechanical failure of colposuspension usually results from the suture pull out at vaginal end rather than at much steadier Cooper's ligament. Now care must be taken to leave a suture bridge, whereby the sutures are not on excessive tension. Here we utilized Hemolock to adjust adequate elevation and tension on both sides before final tying. Assistant fingers at vaginal end can also guide for the same. The idea is just to give stabilization, not tension due to overcorrection. Final bladder filling and check cystoscopy done to rule out any injury to urinary tract. Adequate hemostasis preclude use of any abdominal drain and the closure is done in usual manner. In past, While chasing minimally invasive ways of surgery, we just dropped this novel method of treating stress urinary incontinence. But that was era when laparoscopy or more advanced robotic routes were not available. Who thought of today's situation when synthetic mesh are in dispute? And now we are again ready to adopt this technique because now it can be done even in minimally invasive way. I hope you find this video helpful in understanding all aspects of this surgical procedure. Thank you.
Yes, madam. That is a nice presentation. Now we will have a little bit of discussion. First thing, whenever the patient comes with the urinary leak, in clinical examination, how do you assess the pelvic wall defects apart from the hypermobility of the vagina? How do you assess central prolapse, lateral ligaments, strength? Can you briefly tell a general urologist, even though he is not doing any of these surgeries, when they should refer, they should know. The patient comes, I am leaking urine whenever I get up, whenever I lift some bucket or child, and you examine, usually around 45, 50 years females, maybe completed family life. What pervasive examination findings you like to emphasize before going for any investigations?
So, Dr. Chandra, it's a very important question. And I think whenever a patient with this kind of complaint is coming to you, then the vaginal examination is mandatory. So the thing is, yeah. Hello? Hello? Can you not hear me?
Hello?
Can you hear me?
Yeah, now I can hear, madam, please.
Yeah, sorry for the disturbance. So I was telling that vaginal examination is mandatory whenever a lady is coming with the problem of urinary incontinence to you. And obviously, as you told, that we have to see for any kind of prolapse. So to tell you very clearly that whenever there would be prolapse, especially the anterior compartment prolapse, we shouldn't comment on urethral hypermobility, because we can't see the urethra directly. We are looking at the anterior wall, and it will be loosened in the case of cystocele or anterior compartment defect.
So that automatically rules out going for Burch Colposuspension.
No. It's not like that. We have to address that cystocele separately from the Burch Colposuspension. We have to examine, because the problem of cystocele is that the cystocele is not, you can't define the compartment on looking at the vagina. So the whole of the vaginal wall would be laxed. So you can't comment on urethral hypermobility in case of anterior compartment prolapse. That's the problem. So you have to rely on other things to confirm, yes, this patient is having the problem of stress incontinence. So first thing would be patient's history. The patient is telling you that on increase intra-abdominal pressure, she is leaking. Then sometimes what happens, that patient usually of prolapse will tell you that after having that bulge, they are noticing decrease in their incontinence rate. Probably it is because of the kinking of urethra. So here, as you asked, it is very important, once you are doing a cough stress test to see whether it is a stress incontinence or not, then you have to reduce that prolapse to see how much is the incontinence. Again, for reduction, if you are reducing it by putting finger and making it too tight, like happened with Boney's test. Why the Boney's test is obsolete nowadays, because actually you are compressing the urethra against pubic symphysis.
Mechanically.
It will occlude the urethra, so you won't be able to see any leakage. And actually it was a kind of false negative test. So that's why you have to just reduce, very slightly you have to reduce, so that the urethra becomes straight. And then you have to ask patient to cough. It shouldn't be like too much of the push. It should be a light reduction only. That is very, very important.
Just to make the angle not acute, that's all.
That's very important. Not acute, not very stretched out.
Stretched out also.
Yeah. So second thing would be, we as urogynecologists usually use POC system to report the different compartment defect, but I know that it's cumbersome. Many gynecologists are not able to understand and apply it in their usual practice. So what I will give you a kind of take-home message, that at least see whether this prolapse is coming out of the hymenal ring. That's very important. So simply, if you are not able to do a POC, see by reducing the posterior or apical compartment and ask patient to do a Valsalva. If it is only the anterior wall coming, that means it's anterior compartment defect. And same you can do by putting something, by reducing the anterior compartment and apical compartment. And you can see if some bulge is coming from the posterior side, then it could be rectocele or even rectoenterocele. How to differentiate it between these two things? You have to put a finger into the rectum and like finger in the rectum and thumb in the vagina. And in this way, you are actually occluding the rectocele. And then reduce other compartments. And after that, even then, if some bulge is coming from the posterior apical side, then it could be enterocele. Yeah. Nice. And by putting, speculum on both the sides, anterior or posterior, I usually do it by finger, because even speculum can cause occlusion. So I do it by fingers only. And if you are actually reducing both the anterior posterior compartment, and even then something is coming out, especially it's easy to see uterus, but for the wall prolapse, you have to see it very carefully. So if it is coming down, then it is apical compartment defect. And staging, I will say, two things are important. Usually we don't operate once the staging is below stage 2. That's it's inside, it's not coming out. And the other important thing is that patient should be symptomatic. Symptomatic, like if patient is telling you that she's facing voiding problem, she's not able to evacuate the bladder, or sitting for a prolonged time and having an anterior compartment defect or cystocele, probably that patient require a further investigation in form of uroflowmetry. Just see the flow, and if you find an obstructive kind of flow, then we usually do urodynamics or voiding cystometry by reducing the prolapse. And suppose on reducing the prolapse, the voiding cystometry findings are absolutely normal, then it indirectly proves that culprit is anterior compartment defect. Yeah. So this is the way of investigation.
The second thing, if you have which compartment, if it is there, then Burch Colposuspension you will avoid.
So I clearly told you in my presentation that because Burch you are using anterior compartment, there are chances of posterior compartment defect or becoming more chances of enterocele or rectocele in these patients. So it's not that to avoid. If you have to do a Burch Colposuspension and you're finding, so you can caution the patient. You find that already there is a defect, then it's better to operate simultaneously.
In the early era of TOT and TVT, the cases where Burch Colposuspension is failed, do you think that TOT and TVT have done slightly better job in the earlier of, as you said, 2015 before, when it was peak? Now we are slightly discouraging because of the foreign body and then erosions, then suffering. But when Burch Colposuspension was fading away, the failure cases of Burch Colposuspension, were they corrected by, if it is alone stress incontinence, not intrinsic sphincter deficiency, by TOT and TVT?
Look, if you go for the mechanism of action of all these types of procedures, you will find that there are quite a lot similarity.
Yeah.
Because there are two.
The only thing why I'm asking is the angle in Burch Colposuspension. Please.
Just a second. So the only difference is that in Burch Colposuspension, you are using patient's own vagina and you're uplifting. So that is the one hammock. And in sling, you are actually, if you are using synthetic one, you are actually introducing a separate material for the support. You are reconstructing the pubourethral ligament. So in the case where vagina is too loose or vagina is not having any kind of strength, then probably there are chances that it's getting like patients having some collagen factor deficiency or something. In that patient, probably slings will work better, because you are actually introducing, especially the synthetic one, you are introducing extra strength, foreign material to the patient. Even if you are utilizing an autologous fascial sling, you are actually taking a stronger tissue from somewhere else to apply at that particular area. So that could be the explanation.
Sometimes post-hysterectomy vault prolapse with stress incontinence. After reducing the prolapse also, if the patient has stress incontinence, and urodynamic study proving no urgent continence and bladder stability. When you take the bites sacrocolpopexy, in fact, the urethra will become a little wide open, technically speaking, and leak may increase. Can we add any procedure to sacrocolpopexy like Burch Colposuspension? This I'm asking as a preliminary urologist. I'm asking that in central prolapse, if you have cystocele and enterocele partly also, even then if the stress incontinence is there for patient, not severe, not outside the introitus, just at the level of introitus, we prefer sacrocolpopexy laparoscopy. Very, very commonly I do. Very, very rewarding surgery, provided urethra and bladder are stable. If by chance urethra and bladder are not cooperative, either retention or incontinence increases, we are in soup.
So they are, sorry. Yeah, you want to say something else?
Yes, yes, of course, you have to answer that.
Yeah, so there are two extreme situations.
Yeah.
One situation is there where you are finding that already patient is complaining of stress incontinence, and apart from that, there is a wall prolapse. You are planning for sacrocolpopexy, and you want to ask that whether anything should be done for that stress incontinence. So it all depends on the patient's symptom severity. So if patient is having stress incontinence, sometimes I told you that once you are actually correcting the angle of vagina, the severity of that symptom will increase.
Yeah.
So though it's written in many textbook as well, and it all depends on your patient as well, that you can do, you can counsel the patient and you can do a staged procedure to avoid any kind of complication. But there is no harm if there is a very apparent stress incontinence is there, then apart from sacrocolpopexy, you can do a Burch procedure because you are going abdominally.
Yeah.
The thing is, the only thing which I want to, even answering the second part of your question, that how to avoid kind of severity of stress incontinence. Sometimes it happens that while doing the sacrocolpopexy, over enthusiastic sacrocolpopexy, if you are
pulling too much,
pulling too much and causing overstretching, then again the same thing will happen. The urethra will be stretched. It will be a fixed lead pipe kind of urethra.
So you are creating like intrinsic sphincter deficiency.
Yeah, so you will actually create intrinsic sphincter deficiency, and in these patients, sometimes you will feel like patient will give the history that as soon as they are standing, everything is coming out. The whole urine is coming out.
That's dangerous.
So that's why we have to be very, very careful.
Pulling the...
Yes. So even I personally think, and it is also written in textbook as well, if there would be high grade of cystocele or rectocele, I don't think so you can correct everything by doing a sacrocolpopexy. Always examine your patient after performing your abdominal procedure. If you find a grade of cystocele or rectocele still after correcting the thing, don't try to correct it by putting too much. Better to repair it vaginally.
Correct, madam. Great answer. So ultimately, clinical examination and the patient complaints and which compartment is weak, and a separate assessment of the urethra vaginal mobility, and maybe plus or minus urodynamics about the bladder overactivity. In fact, bladder overactivity, if it is missed, entire thing goes wrong. So these are the basics. And is there any abdominal other procedure for these incontinence procedures or prolapse? Anything other than Burch colposuspension and sacrocolpopexy you are aware of, or you are doing, or not?
We are doing, we are doing sacrocolpopexy a lot, and in fact, we have presented our paper as well.
Very good surgery, I feel, no, madam. Very good surgery.
Yes, it's a very good surgery, and actually, it is said that it's better than other procedures which are done vaginally for apical compartment defect. The reason is that you are able to maintain the vaginal axis in a better way, in a right way. So the chances of recurrence are always least. Especially, you are not compromising with the vaginal length and width. So in a young sexually active lady, it's always advisable to go for sacrocolpopexy, looking for their the mad life and
For
everything.
Burch colposuspension, which suture you commonly use, Proli?
So I am advocate of using always delayed absorbable sutures. Why? Because because I find that whenever, if there would be any kind of, if you are relying on a permanent suture, and if there would be any kind of complication, like in synthetic slings, what happened? Small mesh. So if there would be any erosion or something, you have to cut that thing.
You have to cut that.
I rely on fibrosis. So I think that even for sacrocolpopexy, suturing the mesh at the sacrum, I am using delayed absorbable suture, because even osteitis could be a dreaded complication. So I don't want to use a permanent.
You mean to say that the fibrosis will take care of it?
Yeah. So I have done so many cases, even for sacrospinous ligament fixation. I am using delayed absorbable sutures. I can use PDS as well, which is quite a delay.
Sometimes the suture can come from the mucosa of the vagina. In that case, it causes problem if it is absorbable suture. Sometimes the bite can go through the mucosa also, even if you are, especially in thin paravaginal tissues, you may not get a good bite also in such case.
Yeah. So the thing is, I told you that while doing Burch colposuspension, or even if you are doing a sacrocolpopexy, if you are using delayed absorbable sutures, you are not worried about going through and through. You can take a good bite.
Yes. And especially 20 Vicryl has a good needle, and it will rotate very well. And finally, a few questions, last one or two. When you are pulling, you said that there is urethra, there is paravaginal tissue, there is bladder. Bladder is seen, urethra is seen, paravaginal tissue is seen, vagina, of course, is not seen. You are pulling the threads, and it's not objective, it is subjective pull. Both the sides you are pulling in the air and then tightening. Nobody can say that how much you pulled. Anything from the vaginal side you can imagine, or anything objectively you can see from the laparoscopic side, or Foley's catheter, or cystoscopy. Something should be there to pull it up. How much you will pull it up?
Yeah, so very, it's also a very common question people ask. So the thing is that first thing I tell you that I always do these kinds of procedure, whether it's abdominal as well, in lithotomy position. Okay. I'm not keeping the patient supine. So vagina, I can access the vagina. You can see in my video that the assistant can actually lift the vagina, and assistant can feel that how much tightening is required. The thing is that once you are doing it in an open method, that you can keep your 2 fingers. That should be the breadth between.
You told that.
Yeah. But if you are doing it laparoscopically, around 1.5 to 2 centimeter gap that you have to maintain. You shouldn't make it too tight. Yeah. That is very, very important. And once you will start doing, you can feel that how much
the vagina can easily come up. The suture, while knotting itself, you are sliding actually. That slide strength you will assess by your left and right hand. Then you clip it up.
Yeah, that's very important. You can see that on both sides of the urethra, that the part is vagina only, covered with the pubo-cervical fascia. So once you are tenting, actually you are tenting vagina from vaginal side.
You never faced cut through of the tissue when you are pulling like that. It is a very unpleasant situation when it cut through, because the primary aim is to get the strengthy paravaginal tissue, paraurethral tissue towards the Cooper's ligament. But if it cuts through, you will take deep bite.
Yeah, obviously we have to take a deep bite. And there are few, actually, to avoid that cut through, there are few points which I described, that you don't take single suture, take double bite, It should be horizontal fashion, so that these things are important to avoid a kind of just a cut through from that side. So these things are very important. Never try to pull it too much.
Yeah.
It means that
better to underdo. Like in vaginal sling, we keep an artery forceps before we pull. Whereas in sling, we have to technically imagine how much strength you are pulling. Obviously, in old females, maybe it is little tricky situation to do this. And how often? Last question. How often you are doing in a year this Burch colposuspension nowadays? Honestly, you tell me, when incontinence comes, the procedure which all we prefer is Operative. I like it. I have done it not only out of maybe 30 I might have done. Only 1 or 2 cases, little bit of leak was there. I'm very happy with the procedure. But so much antagonism has come from the UK, and suddenly, I don't know what happened. We are also afraid to do that. We start referring to Sanjay Sinha like that. Why unnecessarily take chance? So what is your opinion? That do you go for sling or do you go for robotic Burch colposuspension?
The thing is that so for last 12 years I am doing slings, and I have done a lot of my patients are with 10 or 12 years follow-up as well, and I didn't find any problem. Even for the mesh erosion part, we are so careful in doing surgeries. We are always checking fornices and everything. So I have never found these kinds of complications. Very rarely, if patient got some kind of fall or there would be some infection, that those unlucky patients might have the erosion, but we can take out that eroded part separately. So actually, it's not a big deal. You all know that it is by lawyers at western part of our world who actually called all these kinds of all the slings are actually defamed by them. So otherwise, synthetic slings, you are absolutely right, are very good. Personally, I do a lot of retropubic sling placement because being in tertiary center, we always get those patients who have very severe kind of incontinence. They are actually leaking with empty bladder as well. So there is component of ISD in these patients. And in these patients, TOT, that is transobturator route, will not give good results. So I always do retropubic slings in these patients.
Okay.
Transobturative, I rarely do in mild cases or patients are having some previous surgeries or something where retropubic route is not possible. Otherwise, I am doing mostly sling procedure. Burch colposuspension, if it is like some abdominal procedure has to be done, or patient already had some radiotherapy, cancer surgeries has to be done, where we don't want to use synthetic material. So then
you are mildly revisiting the not really aggressively revisiting the Burch.
Yeah, so because in India we are having availability of synthetic mesh. I told you that in Western part, even because they don't know how to do Burch colposuspension, nothing is being done for these patients. So
the curve is remaining stable, and as you showed the statistics, the slings are coming down, other two are static. Autologous slings should come up actually by this time. There is every favor for that, but I don't know, abdominal incision, rectus sheath removal, we all feel that it is cumbersome procedure, but those who do say that it is very, very easy, nothing to worry. You can take nice strip and you can pull it up. We feel that nice strip is with incision on the abdomen. And in the era of minimally invasive surgery, people are going for 3 mm ports, measuring 4 mm. In endourology, we measure 2 mm port into the kidney PCNL. So giving a long incision suprapubic region and taking the rectus sheath is not that minimally invasive. So it's a debatable topic. It will go on. Definitely revisit is a correct word. With whatever knowledge, I felt that today you have spoken very confidently, and this talk will be useful. In fact, I have shared the link in Hyderabad, the local gynecological society also, because they will be interested. Knowledge sharing is nothing wrong. And people like you have done good work. I am happy that even in continence trial, from in Indian trial along with Sanjay Sinha, and Mayank Mohan Agarwal is my junior, who is very good in at Lucknow Medanta in your same institute. Excellent in his work, and he is my contemporary. With these words, we will conclude the session, and 1 hour has gone very fast. That means the discussion is good. Thank you, madam.
Thank you so much.
Thank you very much for joining.